Narcotics, opioids. These drugs, such as heroin, morphine, and codeine, are sources obtained by opium, known as the opium poppy seed plant. Opiate agonists stimulate analgesic effects. Opiate antagonists block the effects of opiate agonists. Opiate agonists relieve moderate to severe pain without the loss of consciousness. Generic and brand names. Codeine, codeine sulfate, codeine phosphate. Generic name, hydrocodone. Brand name, Zohydro extended release, Hysingla extended release. Hydromorphone, dilaudid. Generic name, Levofenone. Morphine, morphine sulfate, morphine sulfate control release, Katie. Morphine sulfate, naltrexone, and beta. Oxycodone, brand names, Roxicodone, Oxycontin, Oxycodone, Zamsa extended release, Oxado. Oxycodone with aspirin. Oxycodone with acetaminophen. Oxymorphone. Opana. Opana extended release 12-hour. Abuse lieutenant. Alfentanil, Alfenta. Fentanyl, brand names, Fentora, Actique, Abstra. Meperidine, Demerol. Sulfentanyl, Sulfenta. Metadone, Metadone, Dolafine. Tramadol, Utrom, Conzip. Tapentadol, Nucenta, Nucenta extended release. Adverse effects. Adverse effects that may occur during the initial dose are sedation, sweating, lightheadedness, and dizziness. When a patient is taking opioids, it's best to keep the patient supine to provide safety, comfort, and reduce the symptoms of adverse effects, such as the feeling of nausea and vomiting. Patients who continue taking the medication may begin to feel constipated. Be sure to provide patient fluids to stay hydrated and a diet served with fresh fruit, whole grain products, and vegetables. Serious adverse effects that may occur are respiratory depression, urinary retention, and excessive use or abuse.
Contraindications for opioids are respiratory depression, acute or chronic lung disease, liver or kidney disease, prostatic hypertrophy, pregnancy, increased intracranial pressure and head injury, seizure disorders, hypersensitivity, reaction to morphine. Lactation is a consideration. It's deemed safer to wait 4 to 6 hours after administration to nurse an infant. Additional contraindications may include Addison's disease, severe alcoholism, and toxic psychosis. Some cautions for opioids are medical conditions that increase your risk of dangerous side effects from opioid medications include sleep apnea, obesity, anxiety or depression, and fibromyalgia. Some mental health and substance abuse problems that increase your risk of opioid abuse and addiction include history of severe depression or anxiety, heavy tobacco use, prior drug or alcohol rehabilitation, family history of substance abuse, and personal history of substance abuse. Moving on to patient teaching for opioids. There are many names that fall into the category opioid, and a lot of educating factors are repeated among all of them, with a few details that differentiate itself from each other. To mention a few generic names, there's fentanyl, morphine sulfate extended release, there's hydromorphone, methadone, hydrocodone, morphine, and oxycodone. In patient teaching, you want to go over instructing the patient to take the drug exactly as ordered and not to adjust the dosage without speaking to the provider first. You want to warn the patient of the possibility of addiction even when taking them as prescribed. Inform them that excessive or prolonged use can lead to addiction, misuse, overdose, and possibly death. You want to inform the patient that capsules and tablets should be taken whole and never chewed, crushed, or dissolved. Enough water should be taken with the capsule or tablet to ensure complete swallowing immediately after placing the drug in mouth. You want to be sure to warn the patient to keep opioids away from the reach of children. Accidental consumption of even one capsule or tablet may result in significant respiratory depression and death. You want to caution the patient to avoid alcohol, including medications containing alcohol. The combination increases the risk of overdose, respiratory depression, and death as well. Be sure to inform the patient that long-term use of opioid may decrease sex hormone levels, causing decreased libido, erectile dysfunction, infertility, and lack of menstruation. Some specifics for a few of them are, for fentanyl, you want to warn the patient to never apply transdermal patch if the seal has been broken or if the patch has been cut, damaged, or changed in any way because the drug may be released too rapidly. Morphine sulfate, you want to explain to the patient that they may take capsules or tablets with food or milk to relieve GI distress, and they may mix oral solution with juice to improve the taste. For oxycodone, you want to caution pregnant patients to not increase the dosage or to take for a prolonged period, as adverse effects can cause the infant to experience life-threatening withdrawals when born. You also want to advise women to not breastfeed while taking oxycodone. For hydrocodone, you want to advise women in childbearing age to notify the prescriber if the pregnancy occurs or is suspected, because a fetus exposed to hydrocodone during utero may require treatment for neonatal opioid withdrawal syndrome when born, also known as NOWS, N-O-W-S.
Pain-relieving medications poses a worrisome during pregnancy. Opioid narcotics are not usually recommended during pregnancy. Taking severe pain medications may not harm the baby, but overuse of opioids can cause some delay during labor and throughout the baby's development and future. With any medication, it is always best to consult with a doctor and/or physician before taking any medication for pain. During pregnancy, with overuse dependency on opioids can lead to premature labor and birth, miscarriage, fetal growth restriction, and after labor, the baby can experience neonatal abstinence syndrome. Neonatal abstinence syndrome is a problem the baby can experience as a newborn due to the exposure of opioids. These problems include sleep issues, high-pitched crying, hyperactive reflexes, and seizures. Although neonatal abstinence syndrome is not fatal but can lead to other illnesses throughout the baby's life, it is imperative to consult with a doctor or physician about opioids depending on the patient's situation before pregnancy and as soon as pregnancy is known.
Signs and symptoms of opioid overdose: small or constricted pupil, slow or absent breathing, extreme fatigue, changes in heart rate, loss of alertness. Respiratory depression is one of the most dangerous symptoms because it can lead to hypoxia or inadequate blood oxygenation, which can cause permanent brain damage or even death. Another concern with opioid medication is a slow or stopped heart rate, which can also be fatal. Causes of opioid intoxication occur when someone takes too many opioids, like overdose, mix opioid together, takes opioid without prescription or for longer than prescribed. Certain risk factors can lead to intoxication, including depression, social issue, lack of support system, inadequate treatment for chronic pain. For example, people aged 65 or older or those with memory issue may forget that they've been taking their medication and accidentally take another dose. Separating medication by daily dosage can prevent someone from taking more than the recommended amount. Changes in metabolism can affect the way a medication is absorbed. Those with metabolic disorder must be closely monitored while taking prescription pain medication.
Opioid administration errors may be more frequent and harmful than other medications. According to the MedMarks, an anonymous national medication error reporting database, 644 harmful errors were made in 222 facilities nationwide in 2007. 60% of them were administration errors that led to either underdosing or overdosing. Emission errors were more likely to be associated with fentanyl patches, whereas wrong drug errors were more common in administering oxycodone, often because of the confusion between extended release and immediate release. CDC indicates that methadone, oxycodone, and hydrocodone accounts for most of the opioid overdose deaths. The following are the examples of some unsafe administration errors that can shed some light on the importance of following the protocol procedure. In the article, Medication Errors That Have Led to Manslaughter Charges, on the U.S. National Library of Medicine, National Institute of Health, there are cases derived from various newspapers involving opioid administration errors. Case number 17 in this article involves a state-enrolled nurse who administered 300 milligrams of morphine to a wrong patient in a nursing home. The nurse administered the morphine to a 77-year-old bedbound resident with severe emphysema and pneumoconiosis. He was in the adjoining room to a cancer patient. The paramedic crew administered naloxone and the patient recovered consciousness. However, after being taken to the hospital, the patient had a further seizure and died. The general practitioner and 3 nurses were charged with manslaughter but were acquitted. This case is an example of consequences that follow when a nurse fails to follow 7 rights and facility policy when administering the high-risk medication. Like most of the medication administration errors, Identifying the right patient using two identifiers would have prevented this error. The article Right Place, Right Drug, Wrong Strength in Patient Safety Network is a case of a 2-year-old girl admitted to the hospital burn unit for a 10% total body surface burn. Her medication order included acetaminophen and nonsteroidal anti-inflammatory drugs. Every third day, she was also given oxycodone before dressing change and burn inspection. A week into the hospital stay, the patient was difficult to arouse, lethargic, and arterial blood gas revealed, carbon dioxide retention, and hypoxemia. After reviewing the patient's MAR, the physician discovered that the patient received oxycodone 3 times the prescribed dose in less than 8 hours. After checking the automated dispensing machine, the nurse discovered that oxycodone solution stored by the pharmacist was almost 5 times the drug prescribed for the patient. The patient received multiple doses of naloxone and recovered. This case reveals that confirmation bias prevails when a wrong item is stored in a familiar location, especially in a secured cabinet. As a result, a nurse presumes that oxycodone she has selected is what is typically there and what she needs. Barcode-assisted medication administration and automated dispensing cabinets are not entirely foolproof. It is still pivotal for the nurse to triple-check the medication with the patient's MAR before the administration. The article Focus on Fentanyl is based on a case of a distracted nurse discharging an elderly post-operative patient. During the discharge, the nurse applied a prescribed fentanyl patch of 75 micrograms per hour and gave the patient 3 patches to take home. Also, they provided him a prescription oxycodone PRN every 4 to 6 hours, but the patient died within the next 12 hours due to a narcotic overdose. After reviewing the case, it is evident that the combination of oxycodone and fentanyl led to the death of the elderly patient. Since fentanyl is a powerful opioid pain reliever, the patient education is a critical element of care in its administration. The nurse failed to provide adequate patient teaching regarding the medication, its dosage, frequency, contraindications, drug interactions, signs and symptoms of drug overdose, adverse effects, and other safety concerns. The news article Stafford Nurse Faces NMC Over Fatal Drug Error by Press Association reports that premature twin babies born at 27 weeks received 600 micrograms and 850 micrograms of morphine. According to the hospital's policy and prescriber's order, the 2 registered nurses should have given 50 micrograms to 100 micrograms of morphine to those twins. In reality, a senior staff nurse allowed a junior nurse to prepare and administer the drug to the twins with the help of a junior doctor. The twins died from the complications of extreme prematurity and morphine overdose. There is a lesson to learn from this unfortunate event. A nurse should always stay within the scope of practice established by the state and follow the employing facility policy. When administering the high-risk medications, it is required to be carried out by 2 nurses with required credentials. The doctor weighs in who publishes evidence-based stories about different aspects of healthcare, includes a case of a patient dying due to nursing errors and unmonitored use of PCA. Tyler was admitted to the hospital when his lung collapsed and had surgery. For pain management, he was put on PCA pump, delivering morphine. The following morning, he was found unresponsive and suffered 2 cardiac arrests. The hospital made a partial admission that the nurse did not complete adequate training to care for a patient using a PCA. An internal investigation later revealed that she did not check on Tyler since 9 p.m. The nurse later realized that the other patient in his room complained about Tyler snoring so loudly, which was the onset of opioid-induced respiratory depression. According to the American Society for Pain Management, nursing guidelines on monitoring for opioid-induced sedation and respiratory depression, patients receiving opioids are more vulnerable when they're asleep because the protective wake mechanism for airway support and respiratory drive is absent. The Joint Commission recommends taking extra precautions for patients who are new to opioids or who are restarting the opioid therapy. Tyler's death was preventable if the nurse had completed her training on PCA, known the signs and symptoms of opioid-induced respiratory depression, and closely monitored his vital signs throughout the night.
I will be discussing nursing implications and high alert protocol for opioids. Let's start with the nursing implications. Nursing implications or nursing considerations play an important and crucial role in relating to opioids. Fully understanding of indications, complications, administration, therapeutic, and pharmacologic effects is a responsibility and accountability of nurses. Clinical judgment is one of the keys for decision-making, resulting from critical thinking and clinical reasoning for the improvement of patient care. Nursing implications includes assessing type, location, and intensity of pain prior to and 1 hour following by mouth, subcut, intramuscular, and 20 minutes following intravenous administration. When titrating opioid doses, increases of 25 to 50% should be administered until there is either a 50% reduction in pain rating or the patient reports satisfactory relief. When titrating doses of short-acting morphine, a repeat dose can be safely administered at a time peak if the previous dose is ineffective and the side effects are minimal. For patients on a continuous infusion, they should have an additional bolus doses provided every 15 to 30 minutes for breakthrough pain. The bolus dose is usually set to the amount of drug infused each hour by continuous infusion. For those patients taking extended release morphine may require an additional short-acting opioid dose for breakthrough pain. Doses of short-acting opioids should be equivalent to 10 to 20% of 24-hour total and given every 2 hours as needed. An echoanalgesic chart should be used when changing routes or when changing from one opioid to another. It is very important to assess the level of consciousness, blood pressure, pulse, and respirations before and periodically during administration. If respiration rate is less than 10 per minute, assess level of sedation. Physical stimulation may be sufficient to prevent significant hypoventilation. Subsequent doses may need to be decreased by 25 to 50%. Initial drowsiness will diminish with continued use. For older adults, it is very important to assess them frequently because they are more sensitive to the effects and may experience side effects and respiratory complications more frequently, as well as on the children, because they are also sensitive to the effects of the opioid analgesics and may experience respiratory complication, excitability, and restlessness more frequently. The prolonged use may lead to physical and psychological dependence and tolerance, although this should not prevent patients from receiving adequate analgesia. Patients who receive morphine for pain rarely develop psychological dependence. Progressively, higher doses may be required to relieve pain with long-term therapy. It is also very important to assess bowel function routinely. Institute prevention of constipation with increased intake of fluids and with laxatives to minimize constipating effects. Administer stimulant laxatives routinely if opioid use exceeds 2 to 3 days, unless contraindicated. Consider drugs for opioid-induced constipation. It is very important to assess risk for opioid addiction Abuse or misuse prior to administration. Abuse or misuse of extended release preparations, such as by crushing, chewing, snorting, or injecting dissolved product, will result in uncontrolled delivery of morphine and can result in overdose and death. It is important to explain therapeutic value prior to administration to enhance the analgesic effect, and morphine should be discontinued gradually to prevent withdrawal symptoms after long-term use. Now, let's proceed to high alert protocol, which includes establish guidelines for appropriate monitoring for patients, such as frequent assessment of the quality of respirations and specific signs of oversedation. Ensure resources such as personnel and equipment available. Establish protocols for reversal agents that can be administered without additional physician orders when warranted. Very important to ensure that oxygen and naloxone are available. Providing PCA to confused adults or young children. Establish strict requirements for enhanced observations and monitoring. It is very important to use reminders such as labeling the distal ends of all access lines to distinguish intravenous from epidural lines. Apply warning labels to concentrated forms of morphine and opium tincture, and build computer screen alerts to remind staff about their concentration. Requirement of triple checks with the medications before administration is a must, and differentiation on stock morphine and hydromorphone in strength. Use Tolman lettering for hydromorphone on labels, MARS, EMARS. Use different infusion pumps or epidural and IV infusion, and especially yellow striped tubing without ports for epidural infusions. And just do not rely on pulse oximetry readings alone to detect opioid toxicity. Use capnography to detect respiratory changes. Again, those are the nursing implications and high alert protocol for opioids.
Opioid analgesics relieve moderate to severe pain by inhibiting the transmission of pain signals from the peripheral tissues to the brain, reducing the perception of pain sensation, producing sedation, and decreasing the emotional upsets often associated with pain. They act by stimulating the opiate receptors in the central nervous system in the brain, spinal cord, and peripheral tissues. When the drugs are bound, receptors function like gates that close and thereby block or decrease transmission of pain impulses from one nerve cell to the next. Some of the effects from opioids are analgesia, suppression of cough reflex, respiratory depression, drowsiness, sedation, mental clouding, euphoria, nausea and vomiting, decreased GI motility. Most opioid analgesics are Schedule II controlled drugs and may cause adverse effects. As a result, they all have black box warning regarding safe and appropriate use. There are three subgroups of opioid analgesics: opioid agonists, antagonists, and antagonists. The larger group of the agonists includes morphine and morphine-like drugs. Morphine is the prototype of these drugs, which means they all have similar chemical structures and mechanism of action as morphine. Opioids agonists are well absorbed in these routes: oral, intramuscular, subcutaneous, transdermal, and intravenous. Oral formulations undergo significant first-pass metabolism in the liver, which means oral doses must be larger than injected doses to have equivalent therapeutic effects. For oral fast-acting drugs, the peak occurs in about 60 minutes. IV injection, maximal analgesia, and respiratory depression occurs within 10 to 20 minutes. IM occurs within 30 minutes. Subcutaneous occurs up to 60 to 90 minutes. Opioids are about 30% bound to plasma protein, and half-life is 2 to 4 hours. The duration of action varies from 4 to 8 hours. Antagonists are antidote drugs that reverses analgesia and the CNS respiratory depression caused by an agonist.
An example of this is naloxone, Narcan. When Narcan is administered, it competes with opioid receptor sites in the brain and displaces opioids already occupying the sites. When they are unbound or displaced, they cannot exert their effects in the body. Therapeutic effects occur within minutes after IV, IM, subcutaneous injection, and the duration lasts 1 to 2 hours. They have a shorter duration than opioids, and repeated injections are usually necessary. It is essential that this drug is readily available in all healthcare settings in which opioids are given. Most of these agents produce psychological and physical dependence and may cause serious adverse effects. Physical dependence may develop after 3 to 6 weeks if used for recreational purposes. Physical dependence after pain management is not common, but addiction has been reported. Early signs of withdrawal from opioid use or physical dependence are restlessness, perspiration, goose flesh, lacrimation, runny nose, mydriasis. After 24 hours, signs and symptoms intensify to muscular spasms, severe aches in the back, abdomen and legs, abdomen and muscle cramps, hot and cold flashes, insomnia, nausea, vomiting, diarrhea, severe sneezing, increase in body temperature, blood pressure, respiratory, and heart rate. Prolonged use can also produce drug tolerance. It is when the patient requires increases in doses to receive the same analgesic relief. Patients who have developed tolerance to one opiate usually require increased doses in all opiate agonists. Pain is a subjective experience, and patients' self-reporting of pain is considered a gold standard for assessment because, as it is the most valid measure of pain, failure to properly manage pain is a significant contributor to elevated healthcare costs and poor post-operative outcome. It is important to treat pain as soon as possible with effective pain management and often with combination of strategies. Selection of medications, dosage, and route of administration should be individualized according to the patient's condition.